the attendees to this particular session of the symposium. This is a symposium entitled Medical Ethics and Medical Legal Issues in Bloodless Medicine. And I'd like to introduce the first speaker, Dr. Rowland Ndoma-Egba. Dr. Egba, MBBS FRCS, is a professor of surgery at University of Calabar, Nigeria. He received his degree in medicine and surgery from the University of Lagos in 1977. He became a fellow of the Royal College of Surgeons, Glasgow, in 1986. He's also a fellow of the West African College of Surgeons. Dr. Ndoma-Egba has served as Chief Medical Director of University of Calabar Teaching Hospital for 2 tenures. He's also former Pro-Chancellor of Obafemi Awolowo University in Ile-Ife. Dr. Ndoma-Egba is widely published and has received several awards, including the 2015 Award of Excellence of the Bloodless Medicine and Surgery Society, for his excellent contributions to the science and practice of bloodless medicine and surgery. He's the Chief Patron of the Bloodless Medicine Surgery Group, UCTH, and is a member of several professional societies, including the Bloodless Medicine Surgery Society, of which he is a life member. Welcome, Dr. Ndoma-Egba.
Okay, Dr. Su, your pronunciation has earned you a title amongst my people, because you called it like someone from my village. So thank you so much for introducing me. Good afternoon, distinguished ladies and gentlemen, and from wherever you're watching us, I wish we have a good day. I would like to present my slides now. Okay. My part of the discussion is on compassion and essential quality for ethical surgical practice. As far as discussions I have known, except my dear granddaughters, whom I'm very proud of and I love very much. Beyond that, I have no other disclosure. As plan of my discussion, I will start with introduction and definitions, characteristics of ethics, conceptualizations and explanations, interpersonal factors associated with compassion, action and practical compassion in healthcare, cultivating compassion, and most importantly, can compassion be taught? How do we teach compassion, if so? And finally, the conclusion. As a matter of introduction, I've taken the liberty to give the simplest, non-complex, non-professional or not specific to any profession definitions to the title of my presentation. And for this, I've used the Oxford Advanced Learners Dictionary 10th edition. Compassion is here defined ordinarily as strong feeling of sympathy for people or animals who are suffering and a desire to help them. Quality is the standard of something when compared to other things like it. And ethical is connected with beliefs and principles about what is right and what is wrong, morally correct or acceptable, and usually defined by each group of professionals. Surgical practice here is the branch of medical practice where treatment involves manipulating or cutting open the human body, often removing or replacing parts, and sometimes not even using surgery. Characteristics of ethics. We will remember that the Hippocratic Oath summarizes medical ethics and has evolved over the years with various modifications in keeping with changing times. The seeds of surgical ethics as a specific component were sown by John Gregory and Thomas Percival, who explicitly specified the moral values of a surgeon in the 19th century. Pillars of surgical ethics. One of the most important pillars is autonomy. Autonomy implies that the patient has the freedom of thought, intention, and action when making decisions regarding surgical treatment and care. This also implies other branches of medicine. Beneficence, the surgeon should always act in the best interest of the patient and no other consideration. Non-malfeasance, above all, do no harm. Non-nocere, as in the original, must exercise sound judgment and recognize limits of professional competence. Justice, surgeon must observe policy of fairness and equality of all human beings. Although compassion is vital across the entire healthcare field, it is central goal and tenet of palliative care. Empathy, the Latin root for compassion, is pati, which means to suffer, and the prefix com means with. Compassion originating from compati literally means to suffer with. The connection of suffering with another person brings compassion beyond sympathy, which is appreciating a person's pain and suffering, into the realm of sympathy, which is wearing the patient's shoes. But beyond that, compassion also requires action. Definitions of compassion differ according to the perception from which it is defined. Patients view compassion as a virtuous response that seeks to address the sufferings and needs of a person through relational understanding and action. Healthcare providers view a virtuous and intentional response to know a person, discern their needs, and ameliorate their suffering through relational understanding and action. It is recognized as a standard of care and a core component of patients' healthcare experience. Compassion is how care is given through relationships based on empathy, respect, and dignity. It can also be described as intelligent kindness and is central to how people perceive their care. Competence means all those in caring roles must have the ability to understand an individual's health and social needs. Values of a compassionate system. The 6 C's, according to NHS of UK, recognizes care, where you help the individual and improves health of the community. Improving the health of an individual also improves the health of the community. Compassion means giving care given through relationships based on empathy, respect, and dignity. Competence, all those in caring roles must have the ability to understand individual needs, must have expertise, clinical and technical knowledge to deliver effective care based on research and evidence. Communication, central to successful caring relationships and effective teams, and function of effective teams. Courage to do the right thing, to speak up for the right thing, and to stand for the right thing, no matter how many persons differ. And that is why in bloodless medicine, new as it is, although strange to some persons, it does not mean we have got to give up on fighting to make sure that it is institutionalized. Commitment on the patients and the population, the cornerstone of all activities. Benefits of compassion. Compassion has been associated with positive impact on patients' experience and patients' reported outcomes. It has reduced patients' symptom burden and improved quality of life. It leads to the enhancement of quality of care rating of any system that adopts compassion methods. Characteristics of a compassionate surgeon. A compassionate surgeon recognizes suffering and vulnerability. He seeks to understand the unique circumstances of each patient because they must be different, attempts to alleviate the patient's suffering, and accompanies the suffering and vulnerable patient to a comfortable zone of outcomes. Where there is lack of compassion, it's been observed and has been shown by research that there is increased patient-family complaints, increased health costs, and increased adverse health outcomes. The surgeon and compassion. The surgeon imagines himself or herself as a patient with fears and concerns that go along with being ill. He or she steps alongside the patient, acknowledging their concerns and guiding them into an area of health and wellness through the correction of the illness. Compassionate approaches to healthcare are pleasurable, increase social connections, decrease focus on self, and protect against stress, whether on the patient side or the surgeon side. The benefits abound for both. The pillars of blood patient management. These are the original pillars of blood patient management as proposed by the WHO. One that we optimize the patient's hematocrit before surgery, minimize blood loss at surgery, and support patients' tolerance of anemia. The pillars of bloodless surgery, on the other hand, by bloodless medicine, in addition to the three by the WHO, which includes to optimize the hematocrit, minimize blood loss, is also to optimize tissue oxygenation, in addition to support physiological tolerance of anemia. Factors signifying compassion. Kindness forming relational connection. Authenticity, displaying presence and warmth. Acceptance, understanding, and listening, in addition to helping the patient. Communicating effectively. Being involved, being caring, and gentle. In summary, a virtuous response that seeks to address suffering and needs of a person through relational understanding and action. That's by Sinclair et al. Cultivating compassion. Nefsley et al. In 2015 did say compassion is an innate emotion and part of one's personality at birth. Several studies, however, show that compassion can be taught, and practitioners equipped with tangible skills for improving their professional practice by clinical role modeling, a supportive environment, adoption of reflective practice, and Reynolds et al. Talked of use of compassion involving images, to combat clinical scenarios that challenge health personnel's ability to be compassionate with patients with disgusting symptoms. One will agree that this is a major challenge. Patients are presenting with, in quotes, disgusting symptoms. These are often not intentional, and therefore the ability to use compassion involving images as proposed by Reynolds is a way of combating the inability of some healthcare workers to be compassionate with. The ability of health workers to interact with patients, to deeply share in their experience through their outward expression of their innate virtues, and creating a relational space to do so is paramount to provision of compassion in healthcare and entails being physically present with the patient, seeking to understand their unique needs and emotions, and appreciating the person as a person. Relational factors, skills such as being able to express affection, kindness, tenderness, being able to actively listen, showing understanding, being supportive, were perceived to be more effective expressions of compassion than routine task-oriented care. Clinical communication. A prominent component of compassion in healthcare is clinical communication. Compassion models relational communication, refers to verbal and non-verbal displays of compassion and include by the demeanor of the health worker, by the affect, emotional resonance with the patient, by engagement and behavior, actively listening, especially to the subtext of what is not said, being attuned to nonverbal cues, using silence, paying attention to tone of voice, can help uncover patients' concealed suffering. Taylor et al. 2020 tried to differentiate communication into indicative communication and traditional communication, such that indicative communication takes body language must be accompanied with tone of voice to demonstrate a compassionate intent. Other forms include personalization. Patient will feel more comfortable if there is personalization of this attention and care. Attentiveness as to active listening, body language including smiling, eye contact, and even touch. From the patient's view of compassion, the patients regard compassion as a display of emotion that could help humanize the interaction with patients. Perception may also depend on content of the message. For instance, physicians who provide more optimistic prognosis were considered more compassionate than physicians who went on to give prognosis that wasn't favorable. Euphemisms may be better preferred than the raw stuff. Action and compassion. Action-based components directed at proactively alleviating patient suffering and addressing their needs through tangible means are considered quintessential. Small acts of kindness, such as providing comfort, performing actions that are beyond the call of duty, going above the call of duty with the expectation of nothing in return. These were thought to be compassionate. Rose de Ordonez et al. Advised that we avoid overly biomedical approach, which may represent over-medicalization of an illness. There is need to have competency in the relief of pain, both by pharmacological and non-pharmacological means, because sometimes pain is just supratentorial. Challenges to compassion practice setting. There is no doubt that to be compassionate requires a lot of attributes, including having enough time to spend with the patient so that they can recognize those verbal and even non-verbal communication skills. Organizational culture, the system must recognize compassion as an integral part of the service they offer, and therefore create that organizational structure that allows the health worker enough time to interact with patients. The issue of excessive workload is universal, and many times the health worker is so overworked that he or she cannot afford both the patients and the luxury of paying adequate attention to a patient who needs compassion. Inadequate staffing is another challenge. The clinical environment itself may be such as to detract from the ability to spend quality time with the patient. Advancing technology many times does not allow for the time lapse that should take place, and with the speed of looking after so many patients can become mechanical. Sims et al. Call it intentional rounding, where you just go on without actually spending time to understand the patient. Lack of managerial engagement or support can make it extremely difficult to practice compassionate process. Educational challenges. When there is perceived incongruence between theoretical knowledge and ability to apply it, we say there is compassion distress. And this happens very much with virtually all levels of care, but especially people who are new on the job and who find that in as much as you've been told about patients with abnormal or disgusting symptoms, in quotes, when you come to facing them, there may be a disconnect, and you have what we call compassion distress. Absence of enabler role models who are there to transfer the skills. In the absence of such enabler role models, acquiring the skills can be very difficult. And finding even the enabler role models themselves is difficult because compassion is as old a word as it has been in terms of taking it on as a cardinal issue in medicine. It's only a recent event. Experiential teaching is better than didactic teaching, where you demonstrate clearly how to calm a patient in distress down, how to comfort a patient in distress, and how to take away their pain or suffering is a better taught thing in practical terms. The more educated patients tend to rate staff as less compassionate. Interventions. Gould et al. Have talked of creating an environment for compassionate care, the process of CLEC, to enhance clinicians' ability to give compassionate care. This process can be used to teach some aspects of compassion. Using patient evaluation of emotional care during hospitalization to score performance. Using this technique, it is possible to evaluate, by using the patients themselves, the level of compassion shown by the different caliber and level of healthcare staff. Leaders for Compassionate Care Program, LCCP, is aimed to improve motivation and confidence in healthcare workers. Outcome of care. It is good to evaluate the patient's perception or perspective of what they think comes out of compassionate care. The patients themselves showed that compassionate care alleviated their suffering. It enhanced overall well-being of the patient and positively enhanced augmented quality of care by allaying distress and enhancing their relationship with staff. Those who did not feel compassion had negative outcomes like frustration, being overwhelmed, and lack of dignity and hope. From the physician's point of view, compassionate physicians achieve a better understanding of their patients' issues and concerns. Compassion also helps in construction of supportive and caring treatment plans. Compassion helps physicians to cope with more challenging patient scenarios. Compassionate physicians suffered less from stress. According to Civil Treasurer Compassionomics, the revolutionary scientific evidence and caring makes a difference, improves treatment adherence, speeds healing, which is very much of a concern to the surgeon, reduces unnecessary medical care. Epilogue. Can compassion be taught? Ugia described what he called compassion trichotomy and considered the interdependence of motivation, personal reflection and values, capacity, awareness, regulation of energy, emotion, and cognition, connection, sustained patient-physician relationship. All these influence a physician's level of compassion. Outcome of training. While training is possible, at present, it is adjudged that the outcome of the training of a physician or anybody will depend on innate virtues that the trainee is ab initio. How do we teach compassion if compassion can be taught? The intricacies as to how and what will be required in the training program remains largely unexplored, opaque, and oblique. Barriers need to be reconceptualized as challenges that can be overcome. There is need for conceptual specificity because right now there is so much non-specificity, such that definitions differ, contents differ. There is a growing consensus, however, that compassion is inherently relational and depends on perception. For instance, those who are familiar with geography know that the Greeks and the Cypriots are quite closely related. Most Cypriots look at compassion as empathy and kindness, while the Greek look at compassion as a deeper awareness of the suffering of others and a wish to alleviate it. So we need a consensus and a specificity. Finally, Aristotle has shown us that compassion is a feeling of pain at an apparent evil, destructive, or painful event, which befalls one who does not necessarily deserve it, and which we might expect to befall ourselves or some friends of ours. Therefore, we all need compassion. And a good surgeon should be a compassionate surgeon and give an ethical, confident, well-researched, and up-to-date, including awareness of bloodless medicine and surgery, and all that make for efficient care in a very compassionate way to our surgical patients. Thank you. Thank you for your attention.